respected chairpersons, good morning to everyone. Thank you for inviting me here for this clinical talks. And it's actually a great pleasure actually speaking at an in-person conference after such a long time. A painful and a swollen joint is one of the common clinical scenarios that we come across in practice, and it has various differentials which need a systematic approach. And the best way I feel is to pose a series of questions which can narrow down the differentials. Most importantly, clinical diagnosis is the key, and it has to be supported by judicious use of laboratory and radiology. So the first question to know is that, is this a single joint involved or there are multiple joints involved? And this itself will broadly classify the causes as is evident here. And then the next question to ask is that, are we looking at an acute presentation or a chronic arthritis? And that further subclassifies this into these four compartments, and that helps in approaching the patient. The next thing to determine is that, is it inflammatory, infective, mechanical? A history of trauma, of course, suggests a structural derangement. Fever would favor an infection. A recurrent episode, which is lasting short duration, is suggestive of crystal arthropathy, whereas a severe pain that disturbs sleep at night may be indicating towards a malignancy. On the other hand, a pain that is worst in the morning after a period of inactivity with a significant stiffness lasting more than 30 minutes and improves with activities with certain other clues in history will indicate an inflammatory etiology. And of course, then a clinical examination of the joint can be helped to differentiate between these possible causes. So let's look at each quadrant that we divided. The acute monoarthritis. We know that the most common cause is trauma, septic arthritis, or crystal arthropathy. And aspiration of the synovial fluid remains the key, particularly in non-traumatic cases, to make a diagnosis of septic arthritis. The WBC counts, the culture, the microscopy for crystals are all going to help you. X-rays in particular will be useful for cases of trauma, but they can also help you to clinch a diagnosis in case of a pseudo-gout where you can see the calcification in the hyaline cartilage. Ultrasound can be useful if we are looking at a joint like hip where examination is difficult. It can also classify the nature of the collection. An MRI would be helpful for structural derangements, osteomyelitis, or showing you the soft tissue involvement of an infection. If you look at the next category, that is a chronic monoarthritis, then infection remains the main differential, main possibility here, and imaging followed by a synovial fluid examination remains the first initial step, and then wherever feasible, one would want to go ahead and do a synovial biopsy to establish the microbiological or histopathological diagnosis. If you look at the role of laboratory in this setting, it's very limited because it can't make a definitive diagnosis unless the history and clinical examination are really very supportive of the same. Talking about polyarthritis, generally the initial differential starts with an inflammatory arthritis. In the acute setting, there could be other differentials like viral, infective, or sometimes even a crystal arthropathy in 10 to 15% of the cases may present with a polyarticular involvement. And in case of polyarthritis, the laboratory has to be purely clinical based. We have to realize that there are a lot of false positives and false negatives in the laboratory serological tests that we ask for. They are expensive, and therefore one should avoid asking for an arthritis blanket panel because the results can be often very confusing. So how do we go about investigating? It's the clinical picture, which is very important in a case of polyarthritis. Starts from just the patient demographics, onset of fever, the nature of joint pains, and is there anything else happening at the extra-articular sites like the skin. One can also lay emphasis on the systemic manifestation. Sometimes the clues are there, like an example, loose motions in a patient of inflammatory bowel disease. So the site of pain and the pattern of joint involvement is going to help you ask the relevant test. So if you're looking at a symmetrical small and large joint involvement, we're looking at RA. If you have a spinal involvement, we're looking at spondyloarthritis. And if you're looking at a DIP joint involvement with an asymmetrical small or large joint, with some spinal involvement or a single digit involvement, we're talking about psoriatic arthritis. One should also put some efforts to look at, is there any clue coming from the extra-articular areas? A skin of psoriasis, a tophus, an ocular involvement of iritis, a vasculitic rash, a malar rash. These are certain clues if the patient is carrying along with the joint pain that will help you to decide that what is the best investigation that you're going to ask for. And then once you have had this clinical diagnosis in your mind, one can proceed by asking the relevant tests. And there is no point in asking for a rheumatoid factor in a patient who has a dominant spinal involvement, because as we know, RA does not affect the spine unless it's the cervical spine or the atlantoaxial involvement that we are talking about. So RA factor, anti-CCP can be reserved for symmetrical arthritis, HLA-B27 for spinal involvement, and the ANA and ANCAs can be reserved for patients who have something more than the joint, something systemic, something in the skin. Of course, radiology in a case of polyarthritis is not very diagnostic, but it helps you in differentiating between an inflammatory and a degenerative etiology. And sometimes radiology can also give you clue from other etiologies, like in a case of sarcoid, a chest X-ray may throw some value in the diagnosis. So, to summarize my talk, history and clinical examination remain the most important tool for investigating a case of painful and swollen joint. For acute monoarthritis, if there is no trauma, joint aspiration remains the key. For a chronic monoarthritis, I would prefer an imaging and a synovial fluid or a synovial tissue assessment for microbiology and histopathology. For polyarthritis, a serology which is dominantly based on the clinical pattern and the presence of additional clues. And I would emphasize again that the laboratory has to be used very judiciously. Otherwise, it can be very misleading if it is used indiscriminately and can confuse both the patient as well as the doctor. I thank you for your patient hearing. Thank you.